Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and writer that's been working with CCF for 10 years now. That is 1 decade of my life and career, and I could not be happier or more fulfilled by it. And we have created, I have no idea how many videos over that time. We create live videos like the one you're going to watch today. We create documentary style patient-centric videos and stories. We create treatment-based videos, but all with the same mission in mind, and that is to educate people and raise awareness about neuroendocrine tumors. So if you are new to the show, I want to say welcome. And I think that you should really take the time to introduce yourself and go ahead and start connecting with the other members of the community. This net community is powerful, and the people will support you. And if you are a regular, some of you already are, you're saying hello and telling us where you're from. We'd love to see how far each week this program reaches. So let's go ahead and start saying hey to each other in the comments. Let us know where you are in the world. Before we move forward, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Listen, without their support, we wouldn't be able to do Luncheon with the Experts. Simple as that. But we always have this disclaimer from them, and that is that the opinions expressed by the guest today, as well as the questions that you all, the audience, have asked, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guests and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So that last line is really the takeaway. We're going to give you some good general advice. We're going to hopefully give you some answers to your question, but by no means do we or our guests know your specific case. So take that information and that advice back to your home team, which does, and make the best plan and path forward for you. Because if I've learned anything about this disease, it's each case is unique, and therefore each plan and path forward is as well. Today, I'm very excited to welcome to the show Dr. Dr Mechanick, whom I have worked with before in another capacity. We shot a video with him years ago, and we're welcoming him to the show today. How are you, Dr. Mechanick?
I'm doing great. Thanks, Rain.
Absolutely.
Pleasure to be here.
Yeah, we're glad to have you. So for the folks that might not know you or the role that you fill in this neuroendocrine tumor community, tell us a little bit about yourself and the work that you do.
Yeah, sure. So I'm an endocrinologist. That's my classic training. But I also got involved in nutrition support, particularly here at Mount Sinai Hospital, where I work. So I was in private practice for about 27 years. Now I'm full-time here in the hospital in the Cardiovascular Institute, but I have a general endocrine practice and also direct the nutrition and metabolic support service here at Mount Sinai Hospital. And over the course of many years, primarily because of my association and relationship as a mentee to Dr. Warner, Richard Warner, many, many years ago, I got involved not only in carcinoid, but a lot of the other neuroendocrine tumors and endocrine oncology. Learned a lot from Dr. Warner, and over the course of the years, ended up doing quite a bit of work with nutrition and patients with carcinoid. So in fact, it's really a pleasure to be back. Thanks for having me.
Absolutely. And so folks, I know I talked to Dr. Mechanick right before we started recording today, and I promised him that you'd give him great questions, so don't let me down. But I know that we talk about nutrition every week, and we have had nutritionists and dietitians on the show before, but I know that you all have a lot of questions in that realm, and certainly that's not the only realm that Dr. Mechanick is willing to field questions, but I think that you're going to get a lot of value from him in that space. So you can go ahead and start sending in your questions now. Nothing is really off limits. But just know that if we don't get to your question, that you can always follow up with CCF either here on the Facebook page. You can send them a message, or you can reach them at carcinoid.org. And also know that we can't answer very case specific questions. So try to keep them generic, or we will answer in generic ways. But if it's super specific about your case, it's going to be really hard for us to field those questions. And one thing I always ask you to do every week, if you know someone that would benefit from this session, let them know what's going on. Tag them in the comments. Let's get as many people here as possible. The replay will be available as soon as the show is done today. And starting next week, we'll have it on YouTube for those that aren't on Facebook. And there's always going to be value in watching the replay, or if someone can't make it today, watching that show. But I think the real value is having this interactive one-on-one session. If there's a question someone's been struggling with, getting it across to Dr. Mechanick today is going to be really important for them. So let's get as many people here as possible. And then finally, my second ask that you all do a very good job of every week is if you see questions in the comment section that you also have or you're interested in the answer to, just right under the comment, there's a little option to like it. And if you like it or love it or any of the emojis that Facebook allows you to use, they all work effectively the same way for me, which is to upvote it. It shows me there's a demand. We get hundreds of questions each week. And so if I see 8 people have the same question or interested in that answer, I'm going to make sure to get that question across. So that helps me do my job a little bit better, which is, of course, to serve you. So go ahead and start sending in your questions. Dr. Mechanick, I want to learn a little bit more about what was the connective tissue there that started veering your career into that nutritional space? Is it specifically how it intersects or interacts with carcinoid and with neuroendocrine tumors? Tell me a little bit more about that transition when you went deeper into the nutritional aspect of it.
Yeah, that's a good question. So remember, I first went into endocrinology. That's what I wanted to do.
Yeah.
So you go to medical school, you train in medicine, did my endocrine fellowship. Turned out that when I started endocrine fellowship, that was around the time when the American Board of Internal Medicine mandated that all medicine programs had to have some formal nutrition training program or nutrition education. At the time, right of first refusal went to GI. This is what I was told. They didn't really want to do it. So it came to endocrine. Our division chief accepted it. I happened to be one of the first fellows that was then assigned to train in nutrition. I really took a liking to it. But it wasn't just the simple nutrition. It was really a lot of nutrition support, which is that intravenous nutrition or TPN that many of you have heard about. And it really became a large part of my practice moving forward. So then I was doing a lot of endocrine, a lot of nutrition and metabolic support. And in my discussions with Dr. Warner, who I happen to have known, many years earlier when I was a medical student at Mount Sinai and worked with him on some cases, then it became apparent that patients with carcinoid syndrome, by virtue of the fact that these were endocrine hormone producing tumors in many instances, and in certain extreme cases, there were nutritional aspects that really required specialty training. So that's kind of how I got into it. I think the inflection point, which is the purpose of your question, was during endocrine fellowship, sort of being pushed into that direction of nutrition. It's not a usual marriage of endocrinology and nutrition, but for me, it just happened to converge that way.
Understood. Yeah, thanks for clarifying that. And folks, I would be remiss if I did not send some love to Dr. Warner, who was the founder of CCF long ago, and the father of the current CEO, Keith Warner, and just an incredible, beyond an incredible doctor, just an incredible human being with quite a life story. I've worked with him several times, and I'm never not amazed by what I learned from him. So sending special shout out, special love to Dr. Warner. All right. Well, the questions are coming in already, Dr. Mechanick, and they are in this space. So let's go ahead and start taking them. Effie says 2 questions. Are there hormones that cause constipation? And 2, are there hormones that can cause urinary incontinence?
Yeah, so it's a good question because whenever a patient, no matter what the disease is, has certain symptoms, the questions always come back to me, is it due to a particular hormone? So let's take the first one with constipation. And let me just draw your attention to a medicine that's out there now for diabetes, a glucagon-like peptide 1 receptor agonist, or semaglutide, liraglutide. You've seen a lot of these injectables for diabetes advertised on TV. And it turns out that one of the common side effects is, in fact, constipation. And we used to think that the constipation was somewhat downplayed. It had to do with the diet, had to do with the fact that if people were eating less, because a lot of the effects of these diabetes medicines were to eat less. 70% of food is water. So if you're taking in less food, you'll take in less water. And as a result, you'll have constipation. So the first part of the answer is that it may not be hormone related. It may be related to the diet, may be related to the fact that that if you're not eating enough or eating the wrong foods or too much fiber and not enough water, you'll have constipation. But what we've learned from this particular medicine is, yes, these peptides, these proteins that are made from the small intestine, and in fact, a lot of the other sister proteins can be made from neuroendocrine tumors. They can have effects on the motility of the GI tract, and they can have effects on the transporters in the GI tract that affect water transport. So the answer is yes, but there isn't a particular hormone that would be responsible for constipation. As many of you know, there can be particular hormones that are responsible for diarrhea. That's part of carcinoid syndrome. So vasoactive intestinal polypeptide, a lot of the serotonin related chemicals, the bradykinins, the prostaglandins, they can all affect motility and affect water excretion in the colon and in the large intestine and give rise to diarrhea. But I think the point of the question is, are there other hormones? The answer is yes, but it's more of a family of hormones that do it. So in the same vein, you can have hormones that can affect the autonomic nervous system, which is part of the nervous system that controls a lot of our inner organs, and not only gastrointestinal motility, but also motility of the bladder. And you can have urinary retention in some of those rare cases. Certain hormones or chemicals like catecholamines that you can see with pheochromocytoma, which is an adrenal tumor that can overproduce catecholamines and sometimes actually be related to overproduction of other hormones, and even carcinoid syndrome can affect urinary retention or an irritable bladder, and you can give you frequent urination or polyuria, which is the word for a lot of urine. So I don't think the answer requires having the specific hormone in play, but the broad answer is yes, there can be a hormone contribution to the abnormalities of motility of the GI tract and the urinary tract.
Got it. Thank you so much. And thanks, Effie, for your question. Good to see your name and face again. Oh, next question from Eileen. For someone who has insulinoma, are there better things to eat that will raise blood sugar, but are less likely to add pounds and will not contribute as much to belly girth?
Yeah, so that's actually a good question, a question that we'll get a lot. So the problem with insulinomas are obviously that your body's making insulin when it shouldn't be making it. You make it normally when the sugar's high to drive the sugar into the cells. But when you have a tumor that has lost the ability to listen to what's going on in the environment, it doesn't have those correct receptors or glucose transporters, and the DNA isn't working correctly, so it's overproducing insulin. That's what happens in tumors. Then you can lower the blood sugar and in fact lower it to dangerous amounts where you get symptoms. So you need to always have food coming in if it's not controlled. Look, if it's controlled and it's been removed, then you could be cured. If you're on certain medicines that can control it, then you can eat normally and you shouldn't be bothered by it. But until it's controlled, while that insulinoma is not controlled and you have a lot of insulin, then you need to have some dietary adjustments. Therefore, you need to eat. It's not about eating more, which would be to your point of putting on weight. It's about eating more consistently over the time period, and not only the time period where you're awake, but actually waking up in the middle of the night to eat so you don't go too low at nighttime. And again, this is really in the situation where the insulinoma is not being controlled either surgically or with various medications. So frequent small meals. The glycemic index would probably be somewhere in the middle. You don't want it too high where it has too rapid of an effect, but you also don't want it too low where it's not having that effect to bring the sugar up. So somewhere where the glycemic index is is 50 or 60, somewhere in the middle. Glycemic index is between 0 and 100. Obviously, if you're very low, you're going to want a higher glycemic index food to bring it up quickly to get you out of trouble. That could be a juice or white bread or something like that.
Mhm.
But in general, smaller, frequent feedings, see a nutritionist. That's really the recommendation, because this is sometimes is a little bit too difficult for a cookbook answer. So to see a nutritionist, and of course it should be a nutritionist well versed in insulinomas and other neuroendocrine tumors.
Got it. Thank you for that. And thanks for your question, Eileen. Next question from Raphael. Can turkey tail mushroom supplements be taken during CAPTEM treatments? I've heard of their benefits for increasing killer T cells and helping liver metastasis.
Yeah, so I'm not so familiar with that. Just repeat, what's the supplement name?
Turkey tail mushroom supplements. I'm unfamiliar as well.
Not so familiar with it. I mean,
Okay.
Look, if I had to parse it out, I would just say turkey is something that's higher in tryptophan. That's why you get sleepy after Thanksgiving, and high tryptophan foods are actually good for patients with carcinoid. So if this is a supplement that's designed to have a higher tryptophan, then it would be good. Obviously, whenever you're linking a supplement with a biological therapy or a small molecule therapy or an immunological therapy, that needs to be run by the oncologist who's treating, because a lot of these small molecule and biologics, the treatment dosing and regimen needs to mimic the clinical trial as closely as possible. Generally, an exclusion criteria for clinical trials is you can't be taking these supplements. So that already is a red flag. There are some supplements that are safe, some supplements that are not safe. We wrote a clinical practice guideline on this in 2003 in endocrine practice. The bottom line, discuss it with your doctor. No matter what I would say, even in the answer, the bottom line would be to write your question down, bring the actual bottle of the supplement in for the physician to look at it. And that is a very good specific question for the treating physician.
Got it. And just to clarify, folks, turkey tail mushroom supplement. So it's just a type of mushroom called turkey tail.
Fine. Yeah.
I think the answer and advice still stands. Okay, from Albert. What should my diet be like to take care of possible deficiencies in absorption due to sandostatin suppressing various digestive secretions?
Right. So the absorption issue is actually going to be two parts. The octreotide or sandostatin is really acting in a lot of different ways. The primary way is to down-regulate or decrease the secretory potential of these neuroendocrine cells, the carcinoid cells. A byproduct of that is to not have the detrimental effect of those secretory products, not only on GI motility, intestinal motility that we discussed, but also on diarrhea and some of the other symptoms that someone could have throughout their body. So it's the absorption is a secondary effect of treatment, but it's also a primary effect of the disease itself. So even without being on sandostatin, if you're having diarrhea or having an abundance of these abnormal proteins, there could be problems with absorption. Of course, diarrhea and increasing the motility of the intestine itself can decrease absorption. So let's talk about malabsorption in general. And this would apply to whether you're on or off sandostatin. Malabsorption applies to macronutrients, which are going to be carbohydrate, fat, and protein. And also it applies to micronutrients, which are your vitamins and your minerals. As far as the macronutrients, that really is going to look like somebody who's losing weight, who can't maintain their weight. And it's a big problem from a nutrition standpoint. If it continued and someone developed cachexia and really a severe form of malnutrition, then we start talking about intravenous forms of malnutrition to bypass the intestine until the diarrhea can be resolved. You can take supplements by mouth. These would be protein supplements. The fat supplements that you would take by mouth ordinarily would need to be not a long chain fatty acid, which are most of the oils that are out there, but medium chain fatty acids, which are absorbed in a different way. And then the carbohydrate, you would need to take in carbohydrate in a way that didn't cause symptoms, didn't form a lot of gas. So fiber would not be the best way. It would really need to be the starches, and it's kind of like the same diet that you would take if you had GI surgery. So mashed potatoes and white bread, white rice, white pasta. These would be the healthier forms of the carbohydrate to take in. And then you could even take in some supplements. There are commercial supplements that can get in the calories and the protein if you're malabsorbing. There are, in fact, some supplements that already have pre-digested protein sources that you could take in. As far as the micronutrients go, even before there's malabsorption in carcinoid syndrome, there's already strain on the nutritional status for niacin, which is vitamin B3. What happens is the tryptophan, instead of going into synthesized niacin in the body, is diverted to serotonin synthesis. So you can get a niacin deficiency, and in its worst form, that can be called pellagra. And that's a skin rash, dermatitis. It can affect cognitive functioning. It can affect other aspects of the body. And it gives you a dry, scaly rash, actually a powdery rash in your lower extremities. You can have a deficiency in B12. You need B6 in order to make and utilize thiamine, so you can deplete B6. So actually a B complex vitamin is something to take. Also, there can be low vitamin D that's been studied and found to be low in patients with carcinoid. And that's even before the malabsorption. Once you have the malabsorption, in addition, you can have depletion of zinc. So whenever you have a chronic watery diarrheal illness, you can lose zinc, you can lose chromium, you can lose magnesium, you can lose potassium. So these are some of the other types of blood tests that would be ordered, tracked, and then to take supplemental forms in tablets or capsules or liquids, and followed with blood tests.
Got it. Thanks so much. Folks, if you're just joining us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We are here today with Dr. Dr Mechanick from Mount Sinai in New York. A lot of great questions so far, so keep them coming. Switching gears a little bit, Dr. Mechanick, John says, I have a PNET with metastases to the liver. Would I be considered immunocompromised?
Yes. So once you get the mets to the liver, it's carcinoid syndrome. There are a lot of chronic diseases that you wouldn't even think about that affect the immune system. Obesity is an inflammatory condition that affects the immune system. So anything, autoimmune disease obviously affects the immune system, and the network of hormones and other compounds that are expressed and secreted abnormally with neuroendocrine tumors, that network of proteins interacts with the network of proteins that are involved in immunity, that also involve the cells of immunity. So almost by definition, any type of chronic disease is going to have some interaction with the immune system, and in some way the immune system's off kilter. So I know that the intent of the question was, because I have carcinoid syndrome, does that mean I'm immunocompromised? Do I have an immunodeficiency? Or am I at higher risk for certain types of infections? And the answer is, you could be. It needs to be evaluated. It's something to discuss with the physician. But the low-hanging fruit is, you can assume that there's always going to be some aspect of the immune system that's going to be affected with any type of chronic disease, particularly with carcinoid syndrome. It's a broad bag. It needs to be more fine-tuned. I think it's a great question. to pose to your doctor to have answered. I'll give you another example. Patients who have neuroendocrine tumors that overproduce cortisol, for instance. So that's called ectopic Cushing syndrome, which is a form of neuroendocrine tumor. When you have a lot of steroids in the body, just like if you're taking a lot of prednisone, you're immunocompromised, and you need to take certain antibiotics at times to prevent certain types of what we call opportunistic infections, which are infections that occur really more often in those with immunocompromise. So it's a very good question and a question to pose to your treating physician.
Thanks so much. Thanks, John, for your question. From Nicole, I've been scheduled for a Octreotide scan. I have two questions. Is this the same as an Octreotide scan? And two, how sensitive is this scan in detecting possible tumors?
Right. So it's a little bit outside of my wheelhouse.
Okay.
There are, I can only say, just to orient the question, at the very beginning, all we had were Octreotide scans. There are 6, probably more, different somatostatin receptors. And due to a lot of the work of Dick Warner, a lot of these new, and his travels to Rotterdam and coming back and bringing a lot of this new technology back to the States, there are a lot of other subtypes of the somatostatin receptor. And as a result, new scans, new peptide receptor radionucleotide treatments that are targeted peptide treatments that are hitting all these different somatostatin receptor subtypes. Beyond that, though, I'm not familiar with the performance specificity and sensitivities.
Got it. Thanks, Nicole. If you have another question, let us know. From Monita, could taking glutathione and or carnosine be beneficial for carcinoid syndrome patients?
Yeah, good question. So glutathione is part of glutathione reductase, which is a way in which free radicals are scavenged, primarily around the mitochondria, within the mitochondria, which are sort of the powerhouses of cells. A lot of free radicals are generated there. Glutathione is made of 3 amino acids, cysteine, which is found in a lot of supplements, glycine, and glutamic acid. And that's why each of those amino acids, a lot of times you'll see are purported to be important for free radical scavenging and antioxidant use. Glutathione studies have been done, but as a generic treatment for carcinoid syndrome, I don't think there are enough data that are there to justify a recommendation to say you must take glutathione. Carnosine is sort of an esoteric type of a amino acid related compound. Carnitine is also, carnitine's made of 2 amino acids, lysine, I want to say threonine, but I'm not sure that's correct. They're conditionally essential. So during periods of stress, you could run low in that. I believe it or not, I've had and I don't know if this patient's listening, but there's a patient of mine who very early on, when she saw me, I treated with carnitine because she was having these vague muscle cramps. That's the myopathic form of a carnitine deficiency, and she responded, and she's still on it. Carnosine, I'm not familiar with. I've never really given it to a patient for a specific purpose, but I know it's out there in the health food stores and as a supplement. So I can't really give you a better answer for that.
Got it. Got it. Thank you for that. All right. Here is a big one that a big narrative that we often hear. This is from Karen. Does eating sugar cause growth in tumors?
Yeah. So great question. I have a long history with this question.
Yeah.
And a lot of it is actually on the internet. So I was involved with some patients that wanted to take hydrazine sulfate. And hydrazine sulfate is an essential ingredient in rocket fuel, but it's a inhibitor of gluconeogenesis, which is the way in which the liver makes sugar. And there were some studies in Russia early on that there were miraculous cures of cancer by taking hydrazine sulfate. Certainly seen in some animal studies. Some of these animal studies were replicated in Syracuse at a research institute. There were some limited human studies, but in general, no. There are no conclusive or compelling data that would argue that this particular pharmaceutical given specifically to lower blood glucose levels translated into a benefit for patients with metastatic cancer. So let's just look at the question. There are some animal studies that are done. There's this presumption that because tumor cells work off of glucose, and in fact, tumor cells have very little ability to work off of alternate fuels, this dependent on glucose. So if you lowered glucose, maybe that would help. But certainly if you gave glucose, there was a presumption that that would hurt, that would cause the cancer cell to get worse and hurt the human being with that cancer. So the bottom line is no, this is not the case. There are no data to support this that are compelling, trustworthy, well-controlled trial data to show that giving glucose makes cancer worse in human beings. And in fact, we have innumerable studies with nutrition support. And in fact, one could argue the opposite, because by depleting the glucose, you're actually selectively hurting the host more than you're hurting the tumor. The tumor doesn't have a lot of doesn't have insulin receptors and glucose transporters. The glucose goes down the membrane passively. So it's really about other types of therapy. This is not an effective metabolic therapy in humans. You're going to hear this a lot when I get consulted for TPN, IV nutrition in the hospital. Every once in a while, I have a patient who's extremely reluctant to take nutrition support, even though they're starving to death. And it takes a while of good messaging for them to accept the nutrition support. Now, having said that, I don't overfeed carbohydrate in my patients on nutrition support. That's not because I'm afraid of the adverse effect of lots of glucose on cancer cells, but I also don't want to hurt the liver with overfeeding carbohydrate. I want to make sure I'm not inducing a hyperglycemia, high blood glucose level in the individual. So there are reasons why I temper this. And yes, older studies used much higher amounts of dextrose, which is a form of carbohydrate, in the intravenous fluids and the IV nutrition. So you can see how a lot of the data was contaminated by bad studies and by different ways in which we did things. But currently in 2022, modern nutrition support and nutritional approaches to carcinoid syndrome are not based on the premise that glucose causes cancer to grow.
Thank you for that. Yeah, I know that is a popular one. I have a question from Miranda, who says, I've been having some tenderness in my abdomen and I had an appendectomy and they found a net. I go back in May for my 6-month scan. And the question is, should I be worried? And I know that's a big question. It sounds like Miranda is very new to this journey. So how about, like, what are some of the things that Miranda should be focused on and concerned about?
So Miranda, I'm going to just speak to you the same way I would speak to any of my patients who come in with a new diagnosis, whether I'm making the diagnosis or whether I'm treating them for a thyroid nodule and they come in with a new diagnosis of a lesion in the pancreas or a lesion in the breast or something like that. Mm-hmm. It's 2022. We're really good at managing malignancies now. With the advent of biological therapies and small molecule therapies, very sensitive scanning, very well-trained oncologists that are in the community that are out there, you'll do fine. You'll do well. I think the rules are to make sure you have a good doctor that you trust, to listen to your doctor, to generate questions so that your questions are answered, and they'll clarify what it is. They'll present you with what the options are, and they'll get control. They'll get in front of this. So bear in mind where this is coming from, where my answer is coming from. We're in the age in medicine now of prevention or early detection. 20, 30, 40 years ago, it was commonplace for someone to come in already with widely metastatic and disseminated carcinoma. So you're already behind the 8 ball with it. Nowadays, even though we still know how to treat that, people are coming with smaller initial tumors. So we're in front of it. We can get control of it. But the important thing is to not delay and work with your doctor, get your questions answered, and get these tests done to get it clarified, have your options, and then get started with this and conduct your life at the same time. So live your life at the same time while this malignancy is, or cancer may not even be a malignancy. It may just be a benign tumor, a benign neuroendocrine tumor. Let's just get it clarified. And let me just close with a final word, which you can interpret as good or bad, depending on what your frame of mind is. We're living longer. We're living healthier. We're going to be living with these conditions. You can already see the lifespan. And for those of you on the call who can remember considering people in their 60s or 70s back in the 60s and 70s, these were older people. And if they had a diagnosis of malignancy, it was really bad news. Now, people are walking around, they're survivors, they've been treated. Yes, there's some bad cases. You got to stick with it. There are many more that we have control over, and we live our lives with it. That's really what this is all about. It's about not just quality of life, but living with this, keeping up with your appointments, working with doctors you trust, and having this mutuality, this mutualism between a patient and the healthcare professional team working together, and not just looking at it as something that's going to be so scary. Just move through it. As Rain said, it's a journey. Move through it, but you'll come out at the other end, and everything will be fine.
Great response. I appreciate that. And folks, if you agree with that, just write quality of life in the comments. And Miranda, as I said in the beginning, I'm not sure if you were already here on the show, but I really encourage you to leverage the community and the people here in the room today, and just in the overall net community for support, for sharing experiences, et cetera. It's a very, very strong community, experts and doctors and specialists, as well as support group leaders, caregivers, and patients. So good luck to you, and come back. We're here every week to help you. Okay. All right. Next question. From Dorinda, taking Octreotide for 4 years, and I'm experiencing numb toes usually at night. Is this a side effect of that medication that you know of?
Yeah, so they're called, the medical word would be sort of paresthesias and numbness. I'm not familiar with that side effect, but again, I'm not really an expert in using Octreotide as much as those who are treating carcinoid. However, you can see peripheral neuropathies, which is adverse effects on the long nerves in the body, not only with neuroendocrine tumors, but really with any type of a malignancy. These are called paraneoplastic features. You can also see it with some other metabolic problems, like with diabetes. Sometimes there are proteins that can deposit on these nerves, these long nerves, and give you tingling. So discuss it with your doctor, and the doctor may want to have you see a neurologist. You can see it as a side effect for a variety of medicines as well. Certain chemo agents can give you some of these peripheral neuropathies with this tingling.
Got it. Thank you. Next question from John, who's here on behalf of his wife, Lorraine. Hey, John, just wanted to send you all some love. She has been on lanreotide injections for months. They're waiting on the replacement of 2 heart valves. And the doctors want her sugars lower so that she can heal well. It seems like after her injections, the sugar levels go up. Is this regular?
Yeah, that's normal. So octreotide or lanreotide, any of these analogs, one of the side effects is that the sugars can go up. Remember how this is working. It's working by the inhibition of a variety of hormones that are being produced. And in the pancreas, it could actually be lowering. We had a question earlier on insulinoma. It can lower insulin. So it's lowering the amount of insulin that's in the body, so your sugars can go up as a result. So the first part of the question is, yes, it's routine. It's nothing unusual for the sugars to go up with any type of a somatostatin analog. Sometimes we're on steroids too, and that can make the sugar go up. Now, why is the cardiologist or cardiac surgeon saying that the sugars need to be controlled and potentially see an endocrinologist? Because yes, high sugars before, during, and even immediately after heart surgery, and valve surgery is heart surgery, is associated with problems with healing. So you have a sternal wound, you have that incision in the sternal wound for heart surgery, you can get sternal wound infections. So you need to have the sugars controlled. Typically, insulin is used after surgery on a routine basis, after heart surgery, on a routine basis to keep those sugars tightly controlled in the 100s. So both of those things sound very reasonable.
Got it. Hey, thanks. Thanks for your question, John. Well, this is not a question, but just a statement from Ursula, who's our friend from South Africa. PET scan results looking good after the 5th round of PRRT. Lost 9 centimeters of tumor so far. Stay positive, everyone. Great news, Ursula, and thank you for sharing with us. I know that's something being discussed in the States now, follow-up rounds of PRRT. I believe the standard is 4, right, Dr. Mechanick? Right. But she is in South Africa, and so she had 5 rounds. Teresa says, I had a consultant in upstate New York regarding a liver transplant. Of course, no case is the same, and was told neuroendocrine cancer presents its own set of complexities. But the question was, I just lost it, was about live liver transplant. Thoughts on this? Possible, not possible?
Yeah, I'm not going to be able to, and it's a little outside of my wheelhouse, and but the transplant surgeon should be able to answer those questions.
And I will also say that we have lots of videos. As I said in the beginning of the program, we have videos on surgery, which does cover transplantation, which is a topic that's, under, I won't say controversial, but it's, constantly discussed from what I understand in the community. But we have a video that you can access. It's not a luncheon with the experts. It's a produced video about surgery that may help answer some of your questions. So hopefully that helps. Back to carcinoid syndrome. Karen says, does carcinoid syndrome cause high and or low heart rate?
So again, it would be an indirect effect of the various substances that are produced by these neuroendocrine tumors. So look, the easy example would be if you had a neuroendocrine tumor that was making a catecholamine, it was making certain prostaglandins or bradykinins, and they can be associated with a faster heart rate. Slower heart rates are something else. It would have to be indirect. Maybe it was associated with a low thyroid. Maybe it's associated with some direct effects on the electrical system of the heart. That would be less likely. But the faster heart rate as a direct response to the chemicals is a possibility. The second mechanism would be indirectly as a result of fluid losses from diarrhea, anything that's causing inflammation, fluid losses, dehydration, the stress that can indirectly activate the sympathetic nervous system and cause a fast heart rate.
Got it. Thank you very much. And thanks, Karen. Next question from RM. RM says, and this is a common question, if you don't have somatostatin receptors, what is the best imaging tool to monitor tumor growth?
Right. So if you don't have the somatostatin receptors, then obviously that type of scanning where it's looking for the receptor can't be done. And that's a functional scan. but there are still other functional scans and there are still anatomic scans. So the anatomic scans are going to be your CAT scans and your MRIs, for instance. And other functional scans would be your PET scans that are looking at 2-deoxyglucose, which is the overall metabolism of different cells. So cancer cells have a faster metabolism. They're going to be taking up oxygen and they're going to be taking up glucose, and 2-deoxyglucose is a marker for the metabolic rate. You'll see those cells light up more because they have a faster metabolic rate, independent of whether that metabolic rate is linked to carcinoid or linked to somatostatin. So it's not going to be as specific. It won't have the specificity of a receptor scan, but it will still be sensitive and show you that there is a functional tumor there. Now, just because the neuroendocrine tumor doesn't express somatostatin receptors doesn't mean that it isn't expressing other peptide receptors, and a biopsy can show that. Various other testing can show that. And if there are commercially available scans or even investigational scans looking for these other peptide receptors, they may be tried to image initially, stage, and then follow up for response to therapy.
Got it. Thank you. Folks, we have about 15 more minutes with Dr. Mechanick, so we're going to keep plugging along and answering some of your questions. Great questions today, by the way. Bridget says, is there a blood test to routinely check our vitamins and minerals so we know if we have a deficiency rather than waiting for symptoms to present?
Yeah, so this is really a key question for those who are listening. The answer is yes, the tests are available, and the problem is the doctor thinking about doing it ahead of time.
Mm-hmm.
So let me just go off on a tangent a little bit for perspective. The perspective would be patients prior to bariatric surgery or immediately after bariatric surgery. We know in bariatric surgery that patients are at higher risk for certain deficiencies of micronutrients. So do you wait until they have a symptom and then check? That's the point of your question. Or do you anticipate and check ahead of time? So the same can be applied for carcinoid. Would you check every single vitamin known to man ahead of time and keep checking? No, of course not. It would be cost prohibitive. It would just be statistically useless because it's still pretty rare for a lot of the esoteric vitamins to appear as deficient. So it's all based on risk. So the physician needs to assess what are the risks going to be, not only with the particular type of neuroendocrine tumor, but also what's the anticipated treatment, and is there going to be any anticipated surgery to the GI tract that could then cause a malabsorption, abnormalities of absorption. Based on that, then you can come up with a profile of various micronutrients to check. So for instance, vitamin D, 25 vitamin D would be something that might be checked early. Niacin, for instance, if someone had active carcinoid syndrome, I might check a level, but I would certainly just start treating with niacin, 25 to 50 milligrams, usually twice a day, because I know there's such a high risk for a decrease in niacin. If you felt more comfortable getting a level first and titrating, adjusting the treatment to that, you could do it. For B12, you could check a B12 level, but a more sensitive marker is a test called methylmalonic acid, methylmalonic, NIC, methylmalonic acid, which is a very sensitive marker for B12. You can check B6 levels. But again, you want to go to an expert who knows how to interpret. A lot of people have high B6 levels due to other aspects of their normal metabolism. And also if someone's taking a vitamin, sometimes B6 levels could be high. You can get zinc levels in the blood, zinc levels in the urine. You can get chromium levels, though they're a little bit more difficult and sometimes contaminated by some incidental chromium that could be in the needle or the the lab when they're assaying it. And then there are other routine tests like potassium and magnesium and calcium that can be checked. Those aren't vitamins, but those are minerals. So the answer is yes, they can be checked. There needs to be some thought that goes into it, but I would certainly try to anticipate the deficiencies long before someone would develop the deficiency and unfortunately develop the symptoms. Great question.
Got it. Thank you so much. I appreciate that, Bridget. Next question from Wendy. Wendy is a Whipple patient from the Whipple procedure. And so the question is there a diet that she should follow, or is there certain things she should avoid after having that type of procedure?
Yeah, so one of the issues with the Whipple is that it exposes you to a higher risk of what we call pancreatogenous due to the pancreas. We used to call it secondary, but pancreatogenous diabetes. And the type of diabetes that one gets after pancreatic surgery is not only are you removing the cells that make insulin, that mean you might have to go on insulin, you have high blood sugars, not enough insulin, but also removing cells that counter the effects of insulin, like glucagon, so that if your blood sugar were to go too low, you don't have the normal hormonal response to bring it up. So not only do you have a risk naturally of having a high blood sugar, like someone else with diabetes, but you have a risk of having a low blood sugar. Therefore, the diet needs to take that into account. And just like I mentioned before with an insulinoma, this is a diet that should have frequent small feedings, which, by the way, is the recommended diet for someone with carcinoid. Instead of having larger meals, high-fat meals, you want to have smaller meals, maybe 6 meals a day, a smaller meal, a snack, a smaller meal, a snack, a smaller meal, a snack. That's healthy eating for patients with carcinoid, healthy eating with patients after a Whipple. You also want to ask your physician about pancreatic enzymes because of exocrine pancreatic insufficiency, the inability to digest fat and other aspects of nutrition. And you take these pancreatic enzymes with a meal so you don't malabsorb fat and have that oily type of diarrhea or bowel movement after you eat. There can be some motility issues afterwards, and that's why the smaller, more frequent feedings. You want to make sure you take in enough fluid. Because there can be fat malabsorption after pancreatic surgery and a Whipple, you want to make sure, and this gets back to the question we just answered, you can anticipate potential deficiencies of fat soluble vitamins A, D as in David, E, and K, and check those levels. And if they're low normal or frankly low, to start supplementing in those vitamins long before you would get a deficiency state that all of a sudden someone would discover a few years later. You want to stay on top of it. So again, discuss this with your physician. Ask to meet with a nutritionist, an RD, RDN nutritionist, and that way get on top of it. Take responsibility as the patient and get in front of this.
Lovely. I appreciate that so much. Great answer. From our friends at Nets Mexico. This is an interesting question. Are there any neuroendocrine tumors that could cause photophobia, like light sensitivity, I think, or any visual impairment symptoms?
Wait, just repeat the question one more time.
Are there any nets that could cause photophobia or any other visual impairment symptoms?
Yeah, so again, I think nothing comes to mind offhand. I could be wrong. I'm just not aware.
Yeah.
Vitamin A obviously is more associated with night blindness, but not necessarily a photophobia. High tyramine is associated, when you have tyramine, it's associated with migrainous headaches. And a lot of times with these migraine headaches, you can get photophobia. So I'm just trying to pull this together with you as if you were a patient. A lot of times when you ask these questions, the answer isn't necessarily a direct connection between the neuroendocrine tumor and the symptom you're asking about. A lot of times they're indirect. going through abnormalities in nutrition or changes in the autonomic nervous system, or some supplement or treatment that you're also taking for the neuroendocrine tumor that you're treating. But other than a paraneoplastic symptom, which can occur, you can get neurologic problems, brain problems, which are associated with a variety of different cancers that make substances that can affect brain tissue. So besides that direct connection, which could do it, there could be some of these other indirect connections.
Got it. Thanks, folks. We got just a little more than 5 minutes left. We're going to keep moving along while we have Dr. Mechanick. Pam says, it's been 3 years since a carcinoid tumor was removed from my husband's intestine, and he has had nothing show up since. That's great news. But the question is, does carcinoid always return?
No. There are a lot of people who have carcinoid who have successful treatments, and I'll find out about it because they're still followed. They're still followed and monitored to make sure it's not returning. So I'm not saying you leave town and you go somewhere and never see a doctor again. So you're still followed. That's surveillance. That's long-term surveillance. And then if it comes back, you're picking it up early and you get it taken care of. But I have a lot of patients who come in to see me for an unrelated problem, and part of their medical history is, oh yeah, I had carcinoid, 15 years ago and treated by Dr. Warner. And I still go and have follow-up once a year just to make sure I have some bloods checked. But sure, just like many, many other malignancies, they can be managed, and the patient can be in a very long-term remission.
Thanks. From Kathleen, what do you think about fish oil tablets for NET patients, which is a common supplement?
Yeah, so fish oil, the purpose of asking about fish oil is because of the omega-3, which is an anti-inflammatory component. So first of all, not all fish oils are the same. Not all supplements are pure. Many are, and the word is adulterated. The manufacturers add other chemicals that they don't responsibly put on the labels. So you have to be very careful to use a reputable brand or a recommendation from your physician. Not all fish oils are the same. There are proprietary and commercial fish oils, for instance, for high triglycerides that are very different than the dietary supplement fish oils that you find over the counter in the pharmacy. Fish oil, if you're using it as a supplement in any condition, the premise of using it is to decrease inflammation. And part of one of my earlier answers was that almost in any chronic disease, there's inflammation. So based on that reasoning, one could argue, gee, guess I should take fish oil all the time for anything. So the answer is no. And now I'm going to just introduce a little of my bias. I would rather that people consume these healthy molecules in a healthy format, which is whole foods. I would rather that you have a dietary pattern that includes fish, cold water fish, with the natural source, along with all the other healthy molecules that are part of a fish, rather than taking it in a capsule as a dietary supplement, unless there's a very specific medical indication to take it. So that's point one. Point two, fish oil is not without complications. There are sensitivities, but there can also be bleeding. It can adversely affect platelet function, and you can get bleeding with it. So my answer would include this recommendation to those listening. All the time when you're taking a dietary supplement, you must report it to your physicians. There was a study by Eisenberg et al., New England Journal of Medicine, late 90s, 2 papers, that the majority of patients fail to disclose the use of dietary supplements and nutraceuticals to their doctors. Doctors need to know about this because there are nutraceutical interactions, there are nutraceutical medication interactions, there are food, nutraceutical interactions, and there are just side effects of nutraceuticals, meaning high potency dietary supplements. So they need to be reported just like you report your medicines. So where you have your little piece of paper tucked in your wallet with all of your medicines, or if it's in your electronic health record, you need to have all your dietary supplements there. If you're not sure, bring a list of the ones you're interested in and run it by your doctor.
Got it. Thank you very much. Quick question from Sherry. This is not for you, Dr. Mechanick. Just says, I missed the first 45 minutes. Is this recorded? Absolutely, Sherry. As soon as this program is done here in a minute, it will repost itself as a permanent video under the videos tab on Facebook. And starting Monday of next week, I will republish it to YouTube for those that don't have Facebook. So you can always go back and watch the replay. And again, I'll reiterate, there's a whole library of, lots and lots of videos we've done. 2 years worth of Luncheon with the Experts alone. That doesn't count any of the other stuff. And Dr. Mechanick, I had a comment for you from Bridget, who said, thank you so much for sharing in such relatable language. I have to kind of +1 that. I think you did such a great job of explaining it simply for people to understand.
Thanks.
So I appreciate that. And also, this is a total side note, but also a special shout out to your enunciation, because if you've noticed, folks, you have to turn on this feature, but there's closed captioning if you want the subtitles on your Facebook page, and it does it live. It's transcribing that live, which is very hard for AI to do, even though it is intelligent. And when you enunciate like Dr. Mechanick, it does a great job. And some of these tough health words, medicine words, he gets across so clean that you can see it in the transcription perfectly. So that says a lot about that. Dr. Mechanick, I appreciate your time so much. Thank you for being here with us and sharing your knowledge and experience.
Thanks, everyone. Thanks for having me.
Absolutely. And folks at home, we thank you as always for being here. And we hope this program helped answer some of your questions. And if not, reach out to CCF either at carcinoid.org or here on the Facebook page. You can send them a private message. Thanks as always to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, this program wouldn't be possible. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. Happy St. Patrick's Day. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.